I'm Steve Adubato. More importantly, I am pleased to be joined by Dr. Richard Rosa, who is the co-director of the Joint Institute here at Saint Barnabas Medical Center. Good to see you, Doctor.
Nice to see you.
Let's talk about knee replacement. First, who is the most typical candidate for a knee replacement?
Candidate for knee replacement is a patient who has arthritis in the knee that has not responded to conservative management and is having severe pain. And the age can range anywhere from the 50s up until the 80s or even 90s.
And this treatment is a treatment that you said is more personalized in terms of really looking like a knee. And this knee replacement, huge. Talk about it.
A patient-specific custom knee replacement. It was developed by a company in Boston, Conformis. What we've seen over the last, say, 10 years is an evolution of knee replacements to a more anatomic design to match patients more accurately. This is the ultimate. It's a patient-specific design. The implant, or the design of the implant, is generated from a CT scan and interpreted by a computer. The end result is a knee implant that matches the patient exactly in every aspect.
Compare that to knee replacement 10 years ago to this. What's the difference?
Well, 10 years ago, we have instruments. We would make cuts, and what we're doing in knee replacement is we're resurfacing that knee joint, but we're also restoring the alignment and trying to balance the ligaments. Now, there is some human error there. No matter how good you are, there's still some human error. So what we do in the past is we would have a choice of maybe six sizes that we would use. We would make our cuts and we'd pick a size that was closest to that patient. And generally, it would fit well and it would work relatively well. But what might happen is it might be a little bit too small or a little bit too big. If it's a little bit too big, you might get some overhang of the implant, so the patient might notice a prominence. It might cause a little bit of pain afterwards, not like the pain they were having before. This particular implant, it matches that patient specifically, so it's an exact fit. There is no overhang, and perhaps even most importantly is that we can perfectly balance the ligaments so that it should feel more normal, more natural to the patient.
Continuing to talk about this newer surgery that's been around for a little over a year, as you said. Minimal cuts?
Minimal cuts, we're taking as little bone as we possibly can. The advantage is that if we need to do anything in the future, we've preserved a lot more bone, yes.
Okay, now for someone who, say, is in their 50s, active, plays tennis, wants to exercise, better outcome for that person getting this particular knee replacement?
Oh, absolutely. If we take an older person who say they're late 70s, late 80s, their physical demands generally are not as great as a younger individual. They're going to tolerate more. They just need that relief of pain. They need to be able to walk around the house, go out sometimes. A younger individual wants to stay as active as possible. You take someone in their 50s, they want to be up, they want to be out with their children, with their grandchildren. They may be playing tennis, they may be doing some brisk walks or even some light jogging, and they're going to notice it a lot more. They're not going to tolerate the little imperfections as well. So these are the people that probably benefit the most.
Describe that scene, Dr. Rosa, what was 15 years ago, 20 years ago, versus what is in terms of what equipment was there, what is there today?
Well, that's a good question. What was, even a year ago, we're using instruments that come from the company, and they're specific for each knee. And for any given patient, we might have 6 to 8 large metal trays full of instruments that weigh a ton. And these need to be prepped, they need to be cleaned, they need to be sterilized. With this new knee, the computer-generated instruments are just a small box of high-density plastic instruments that match that patient specifically. So it really cuts down considerably on the amount of traffic flow in the operating room, which in the end theoretically should help us to decrease the incidence of infection.
Rehab, though, always very important, even with the new surgery, right?
Rehab, I wouldn't want people to think that it's a magic answer and they're going to be in and out of the hospital in 24 hours. I mean, after a knee replacement, it takes a lot of hard work on the part of the patient. They need rehab, they need physical therapy for a good 3 months after the surgery. But again, the advantage of this knee is that since that knee should feel more natural and since the ligaments are perfectly balanced throughout the arc of motion, theoretically, they should be able to rehab more quickly than someone with a standard knee replacement.